right. Well, thank you, everyone. And hello. Excited for today's session. I want to welcome you today. My name is Jenna Groman. I'm the Director of Global Community Practice at the Sabin Vaccine Institute. And we are thrilled to have you all join us for today's session on staffing considerations and staffing models for COVID-19 mass vaccination sites. Next slide. Just a few instructions and logistics for today. Please do make sure you are on mute when not speaking to limit background noise and feedback. You can engage in dialogue through the chat window with your peers and with the facilitators. Please test the chat now, share your name and where you're joining us from in the chat window. And you can also share questions throughout today's session in the chat window. We will have time at the end of the session to answer your questions with our presenters. And so we hope to hear from you quite a bit during today's session. Next slide. The Global Mass Vaccination Site Collaborative is a collaborative that is hosted in partnership by the Boost community at Sabin Vaccine Institute and Ariadne Labs. A joint center for health systems innovation at Brigham and Women's Hospital in Boston. And the Global Mass Vaccination Site Collaborative is an initiative that's aimed at providing resources, tools, and experts to assist vaccination site operations, primarily in low and middle income countries, both to help inform operations and capture the lessons learned throughout all of the mass vaccination site operations that have been being conducted throughout the globe. So the collaborative features an open access website at globalmassvaccination.com, and as well as a learning group on the Boost community where you can access resources, tools, conversations, and events related to mass vaccination rollouts. Next slide. So we hope you join the Boost community. It's a community of global immunization professionals. Almost 2,500 immunization professionals are members of this community. It's free to join, and you will be able to access resources and learning opportunities to help you advance your careers. And you can learn more at boostcommunity.org. Next slide. And just a bit more information on Ariadne Labs. As noted, it's a joint center at Brigham and Women's Hospital and the Harvard School of Public Health. And they focus on creating scalable systems level solutions for better care now and what's next in healthcare. And they've been working in the global mass vaccination area for really since the beginning of the pandemic, focused with a lot of focus specifically on vaccine delivery. Next slide. And so it's my pleasure today to introduce our presenters. We will start with C.A. Kambire from Village Reach. She's a digital solutions manager at Village Reach, who's going to be talking about the staffing models used by Village Reach at the mass vaccination sites or the vaccinodromes that they've been running in Cote d'Ivoire and DRC. And then we'll also hear from Robert Kanwaji, the COVAX demand generation lead at Gavi, who will both reflect on some of the experiences and lessons learned from Village Reach, and also reflect a bit on his lessons learned that he's seen for staffing for mass vaccination sites throughout both the COVID-19 pandemic and other events as well. So I will turn it over to CA now, and thank you, and looking forward to today's presentations.
Okay, thank you, Jenna. Hi, everyone. Thank you for joining this presentation today. So we are going to talk about the COVID-19 vaccination staff model from the work that we are conducting in Cote d'Ivoire and DRC. Next slide. I'm C.A. Kambire. I'm a digital solution manager at Village Reach, and I'm working right now as a program manager at the Vaccinodrome of Cote d'Ivoire. So I'm going to lead this presentation today. Next slide. Presentation. Wow, effective staffing model is important for successful delivery, and also the things that we should consider when developing a new staffing model, and then take a look at what has been done as a staffing model in Côte d'Ivoire and DRC on the program that we are running right now. And lastly, we'll be talking about the key lesson learned from this experience in Côte d'Ivoire and DRC. Next slide. So very quickly, I want to give an overview about what we are doing right now in Côte d'Ivoire and DRC. So Village Reach is supporting the government from the two countries in the effort that they are having for COVID-19 vaccination. So we are running, we are operating 5 vaccination sites called Vaccinate Home in these countries, and we have 1 site in Côte d'Ivoire and 4 sites in DRC. And since the end of 2021 and the beginning of 2022, we started these activities and have been able to vaccinate more than 40,000 slides. Next slide. Okay, so why it is important to have an effective staffing model? An effective staffing model supports the achievement of the site vaccination goal by identifying the required resources that are needed to deliver the different vaccine. Additionally, it ensures that the vaccine administration process are being well conducted in order to meet the individual needs when they came to the site. And on the other hand, this effective staffing model also help to optimize the capacity of vaccine delivery on a site by ensuring that the clinical and non-clinical staff are delivering a quality care in a structured manner through the collective efforts. Yeah, next slide. So what should we consider when we are developing a new staffing model? So we have many input that we need to take into account when we are doing such kind of work, like vaccination throughput target, the source of staffing, the budgetary concern, the number of essential and non-essential staff, and the compensation structure. So like the vaccination throughput is the input that help us having a good idea on how many people, how many staff we need to hire to be sure that we will be conducted the delivery services of vaccination very correctly. So they help us defining the number of staff that we need for the site. And then the source of staffing, the way that we will try to get the different staff that we have defined by analyzing the vaccination throughput. So, like for example, here in Côte d'Ivoire, we had a government that provides many staff on the work that we are doing. The product, a part of the staff, and the other part of the staff has been hired by Village Reach. And about the budget concern, the main idea here is that we have a fixed budget on the program. So we should be aware of that and try to analyze this information in order to make sure that we are considering the good level, the good cost of model. Over the different salaries, the incentive fees, something like that. So we need to all the time be aware about the budget concern, so that we can be all the time aligned with the different cost level that is required on the program. So in terms of compensation structure, the compensation structure is the way that we plan to pay the different staff, cultivate the different staff. So this is very important, as it has a direct impact on the way that the staff will be delivering the services. So finding the good plan of compensation and incentive is very important in the staffing model development, so that we can make sure that people can be correctly involved in the program. Next slide. So what about the staffing model in Côte d'Ivoire? So in Côte d'Ivoire right now, the staffing model, we have 45 staff that has been hired, and the staff came from diverse agencies in the country. We have a great support from the government. So most of the agencies of the government that intervene in the vaccination activities gave us some stuff, like, for example, the National Institute of Public Health, the Yopougon District Directorate, the ministry, the cabinet of the Ministry of Health, and the other part of the staff has been hired by Village Reach, and most of the time it is the operational staff that has been hired by Village Reach. So we noted that with the diversity of the agency, we need to have a strong processes, a strong coordination process, so that we can bring people work correctly together. So in Côte d'Ivoire, for example, what we did, we have a site director who is managing all the staff from the government, and we have a site operation director from Village Reach, who is also supervising all the activities about all the operations that happen on the site. So the site operation director and the site director from the government site are working tightly together to address the different issues that occur on the program. And all this are being done and under the supervision of the program manager. And also we set up 2 meetings for coordinating the different activities. So we have the meeting which happen every Monday for discussing strategical orientation of the program. And we have another meeting which is set up every Friday for discussing the activities review, to see what are the best practices, the things that went wrong, that the staff need to be aware and try to improve themselves on it. Next slide. Okay, so concerning the development of staffing model, we need to be aware that costing is a very important part of this activities, because by mastering the costing, we are able to understand clearly at what moment we need to make some spend, and on what activities we need to do it, on what stuff we need to do it. So in Côte d'Ivoire, the initial goal of the vaccinatome was to be able to vaccinate 1,000 people a day. So as I said previously, we hired 45 staff that come from the different agencies of the government. And the staff from the government, most of them are working in a shifting rotation, as they stay like employed by the government. So they receive their traditional salary, and they need also to maintain the activity that they are doing with the government. And also by making a shift rotation, they are able to intervene on the vaccinodrome and also do the work that they are having with the government. So over the salary that they receive, the staff from the government also receive per diem, a daily per diem that is evaluated to $9 a day. And the per diem are paid every 2 weeks. At the onset of the vaccination activities, we used to pay the staff by cash. So right now, we have been able to set up a mobile system so that we make the payment by mobile money. And globally, the staff per diem and the village staff salary are estimated at around 30,000. Dollars and the $30,000. These are, so here we didn't take into account the tent rental. Next slide. Next slide. Okay, so about the staffing model vaccinodrome that has been deployed. So for one of them, we have 32 staff that have been hired. And like in Côte d'Ivoire, the staff also came from diverse agencies of the country, like the Kinshasa District Health, and also the National and Provincial API that provide also some staff for DSA, and the other staff, as we did in Côte d'Ivoire, came from village that hired most of the time the data staff and the operational staff for the vaccinodrome. Next slide. So in DRC, the main goal, the initial goal of the activities was to be able to vaccinate between 300 and 500 people a day. So as we have the same configuration in Côte d'Ivoire, the staff that we hired for executing these activities also come from the government, and they have a shifting rotation activities in order to be able to maintain the work that they are doing with the government and also be able to intervene on the vaccinodrome. So we also have some per diem for this staff, and it is $5 for standard expedient, $5 for transportation, and $5 for lunch. And also the consultant salaries and the per diem for the government staff are estimated between $28,000 and $30,000. And the clinical operation supply also are estimated between $17,000 and $20,000. So in this estimation, these are recurring costs, and we didn't take into account the one-time costs like tents and tent setup and rental. Next slide. So what are the strategies that help us to improve the staffing operation? So for improving the staffing operation, we usually we are soliciting the feedback from exit survey from the visitor. This is very helpful for us because from the exit survey, we are able to collect the feedback from the people who are coming to the vaccination. So by collecting and analyzing the feedback, we are able to see if there are some gap on the process that we set up at the beginning and try to continuously improve our process and get people updates to the right manner to work. And also from the exit survey, we are able to have statistical information that that inform us about how we are doing in the community, what kind of, what are the category of people that we are reaching and those that we are not able to reach, so that this helps us to improve our strategy and to adapt our strategy also to the reality. The second thing that we did in terms of improving staff operation is to conduct a weekly meeting and have a training session. So during the weekly meeting that we have Friday, we use to review the different action that we did during the week and try to collect the best practice and share with the different team. And when there are some issue or some difficulty that people are not able to fix, during this kind of meeting, we are able to discuss with the team and found a great way, the best way to address them. And also we emphasize the importance of documentation in vaccination process. This is very, very, very helpful because having such kind of documentation allow us to share very easily the information to the staff and make them have access very, very quickly to the information. Like for example, in the different boxes, we stick the process of vaccine preparation, the process of how to make the vaccination, so that when the vaccinator is in the box, he have access to this information at the same moment. And the last thing is about storing, handling, and administrating vaccine. So the system of storing and handling vaccine on the vaccinatron is very, very important for us because it helps us make sure that our vaccine are safe and in the high quality. And also the fact that we have process, we develop process for administrating the different vaccine. It allows us to make sure that when the visitor came to the vaccinatron, we use the good process to take care of him, so that he can be like a promoter of the vaccinatron when he will be out of the vaccinatron. Next slide. So lastly, we'll be talking about the K learning. One of the things that we need to highlight is that staffing means must be in adequation, and we need to make sure that the patient interaction with the sites are very comfortable and welcoming. Because when the people are coming to the site, it is the way that we are receiving them, which make them be like a promoter of the vaccinatron when they go back at the community. So having the level, the required staff for doing this job is the key that we have to ensure that we be able to execute the work very correctly and meet the expectation of the visitor. And also we continuously need to make an improvement of our tools and process in the way that the staff operates, like in the fixed site or in the outreach in the community. So the continuous improvement help also to always make an update with the staff and make sure that they are continuously having the good information that they need to apply during the different work. So one of the things is also to highlight is that staffing is not cheap. Staffing is not cheap. So during the work that we did, we think that it is very important to try to have a in Côte d'Ivoire with the that we can develop cost sharing with that kind of partner. Next slide. Okay, so also the staffing model needs to be very flexible. The staffing model needs to be very flexible, as a program is always exposed to a modification or an improvement. So we need to have a flexible staffing model that can be adapted regarding the new orientation that or the changement of strategy that occur during during the program execution. And another thing we also want to highlight is that managing staff from multiple agencies requires a shared vision and a process-oriented approach for coordinating and mobilizing team. So in Côte d'Ivoire, the fact that we have team from the government, they were always involved in the national campaign that were conducted by the government, and we developed also on the sites a good leadership with the good processes. This has been the main factor that allow us to make all these people work together very, very easily. And also the partnership with the government enable vaccination staff to ensure that the activities are delivering and complementing the COVID-19 vaccine strategy. Yeah, this is very important also in it has a lesson learned, because as we get staff from the government, they were already working with the government in vaccine activities, in COVID-19 vaccine activities. So by coming to the vaccine home, it looks like the same activity that they are doing. So very easily they adopt the work that they are doing, and they share the vision that we have for the vaccine home. And the last thing is about the per diem, which is very important to set a good environment of motivation, so that when people are paid correctly at the time that they need to be paid. This is something very important from the feedback that we get from our team. Okay, next slide. Okay, thank you very much. Merci beaucoup. Thank you very much for paying attention to this presentation. Over to you.
CA, I just want to say thank you for sharing your experience staffing and supporting these vaccinodromes. We've gotten a number of questions in, and we'll get to those in a little bit. Please continue to share your questions in the chat window, and we'll have time in a bit to talk through some of those responses with CA. But first, I want to hand it over to Robert from Gavi, who's going to share some of his lessons from the field as well, related to key staffing considerations for mass vaccination sites. Robert.
Thank you. Thank you. Let me begin with trying to lay out some of the major challenges before I come into considerations. First, we all accept and know that many of the countries in which we work, there are limited healthcare workers compared to the need. We also know there are other competing priorities. They have teen immunization, they have the primary care programs that they have to deliver, they have family planning programs, and all the other programs that happen within the national health infrastructure. And at the same time, we are setting up mass vaccination sites to support COVID-19 vaccine rollout. So we have a few numbers in many of the countries. There are other competing priorities. And 3, which usually cuts across, but in most cases, this staff are demotivated because they are not paid on time or they are not paid well. And therefore, what could be some of the considerations given those challenges that you have to think about when planning for staffing of mass vaccination sites or mass service delivery sites? So one of them is geographical. We need to be mindful of the geographical areas where we are going to do the mass vaccination program, and ask ourselves what opportunities does the geography of the location of the mass vaccination site provide to us. For instance, is there a teaching hospital that has students, healthcare workers that have a community health program as part of their learning? And that could provide an opportunity for such students and staff that are undergoing training to provide medical healthcare workers to participate in this as part of their healthcare work program. What level of motivation are we able to provide, and what is the transparency and consistency of provision of that motivation? The other one, which Sia has talked about, is partnership or human resources. What partnerships can we put in place, either with teaching institutions, regional referral hospitals, military health facilities, research institutions that already have staff? The other consideration that is key is your daily vaccination rate. How many people do you anticipate to vaccinate per day, given the catchment area? It's important that is taken into perspective. The number of sites, how many sites are you going to set up? What is your overall target of vaccination in that country? What is the schedule going to look like? And once you have your challenges and you have set good considerations in terms of what needs to be done, then you could start looking at how to lay out. And I'm very impressed with what Village Reach has done and presented. Now, what are some of the best practices that I have seen when it comes to mass service delivery sites? Remember, HIV/AIDS programs have used this strategy for HIV testing. Family planning programs have also used mass service delivery sites for expanding the coverage of family planning programs. They have also been used for routine immunization, for safe male circumcision. So it is not something that is new. It has been done before. These are some of the lessons that I could point to that I've seen that have worked to address some of the gaps that Village Reach has raised and that I have just raised here. One, if we don't have enough human resources within the established health system, we need to be mindful that there could be human resources outside that system that we could tap into. And a good example here is in many of these countries, they have teaching institutions for nursing, midwifery, for doctors. And these students are undergoing community health training. And these students in many of the countries are also attached to health facilities or government hospitals where they provide services. As we map out mass vaccination sites, it would be strategic to look at where are these teaching institutions and how can we go into partnership with them so that their students who are actually who are undergoing medical training in nursing or midwifery or in medicine can be part of the service provision as part of their community health work. So that would bring in extra human resource outside the established government system that is available. We did this in northern Uganda for safe-male circumcision. We did it for family planning. And we were able to tap into the teaching, the student teaching resource of doctors, nurses, and midwives, who then underwent training in that specific area. For instance, vaccination, can they be trained into understanding the protocol and the communication that comes with vaccination and what to do so they can be part of the extra resource that can provide services in mass vaccination sites. The other one, a resource that usually is available that's not tapped in, given the limited number, is the military health facilities. Again, in one of these countries, you'll find that the military, the national military runs hospitals where they treat their soldiers and the families of the soldiers. Again, this is an opportunity, again, when I was working in northern Uganda, we had an opportunity to partner with the military where there are doctors, nurses, and midwives who are working in the military health facilities, supported mass vaccination sites in the barracks or in the military catchment areas and outside. So if you really want to solve the issue of limited health workers, could be an opportunity to map out and see how you go into partnership with them so they can mobilize their audiences, but can also serve the communities outside their catchment area. For instance, most of the mass vaccination programs in Uganda, I've seen the Ugandan military participate, whether it is just the issues of triage or issues of organization, client flow, they could help with all that because you still need human resource to do that. Another best practice I have seen is again, multitasking training. So somebody has been hired to do this specific job, but they are introduced to another role and they are trained to play it as part of making use of them if they are not actively being used in the setting where they are located. And then you provide them necessary training and they will be coming to provide maybe half-day service to the mass vaccination site. The other opportunity which I've seen, which is a best practice, is use of faith-based or faith-inspired health facilities and personnel and partnerships, which are also outside the government health facility or system, and working closely with them to expand services outside their catchment area or within their catchment area where communities are mobilized to go and enjoy the mass vaccination program within that catchment area while tapping into the human resources that these facilities bring on board. Again, as you can see, these practices, best practices that I'm spelling out are all intended to solve the issue of one, limited health workers, the motivation and competing priorities, so that we do not, while running mass vaccination sites, at the same time injure or cause unintended consequences to the other routine health services. Another best practice that is critical again is the issue of motivation. Usually governments will use the same healthcare workers when they pay monthly allowance and ask them to participate in mass vaccination sites without any motivation or top up of the work they do. Where mass vaccination sites have been set, some programs set up a good motivation package, just a top up, maybe schedule healthcare workers for 3 hours shift from the nearby health facility, where some come in for 3 hours, go back to the community health facility, another one comes in for another 3 hours, another one comes in for another 3 hours, and they're paid for the 3 hours that they are providing the service. At that time, you are not greatly interrupting the service provision in that catchment area, but you're also motivating the ones that you're using for this kind of work to be done. Those are some of the best practices that I have seen that have been used to solve some of the challenges that I mentioned at the beginning of the presentation. Thank you for listening.
Thank you so much, Robert. I think it's really particularly important to learn not only about what we've seen and learned throughout the COVID-19 pandemic response and vaccine delivery, but also what we've learned from past events as well. You talked a lot about what you saw during Ebola as well. So I think that's just really helpful for us to remember that this is not new. These needs are going to continue after COVID-19 as well. So making sure we can capture those and capture these lessons and remember them for the future is really critical. We've had a few questions come in. I'm going to start sharing those, but just a reminder for everyone you can please share any other questions in the chat. We do have some time to pose those to our presenters today. I want to start with one question for CA, which is specifically about the shift schedule you used. And you mentioned that you used a shift schedule so that government staff could continue their regular jobs without interruption to that. And I was wondering, and the question wondered if you could share a little bit more about what this shift schedule looked like and how it worked. Go ahead, CA.
Yeah, sorry, I lost the question. I got an interruption on my connection, so can you repeat?
Sure. So the question was about the shift schedule that you used at the vaccinodromes. And you mentioned that you used the shift schedule so that government staff could continue their regular jobs as well. So could you describe a little bit about what that looked like?
Okay. So the shift schedule that we are having, like for example, in the vaccinodrome of Côte d'Ivoire, we have the resources, the staff from National Institute of Public Health. They normally provide 4 staff for the vaccinodrome, and we didn't dedicated some staff for the 4. So they didn't dedicate staff for the 4 positions. So depending on the schedule at National Institute, every day they send to the vaccinodrome some staff, some person that will be doing the work of vaccination, or like be a data clerk, something like that. So here in Côte d'Ivoire, what we did is that in terms of shifting, we didn't have like the National Institute didn't dedicated the person to the site, but every day, regarding the schedule that they have at the level, they send a different person to do the work that is assigned to them. In DRC, what is so each time we have to do the work that the other people are doing before. Over to you.
Thank you. And you also talked quite a bit about how you incorporated improvements to your staffing model as you implemented it and worked through this and gathered feedback from exit surveys and staff meetings. Could you share some examples of changes you made to improve staffing operations based on the feedback that you received?
Okay. In terms of feedback, like for example, when we have the information that we collect about the data on the site, it show that for example, the period on which people are coming. We have the most frequentation of the sites, like for example, at the beginning of the week. And at the end of the week, we don't have many people who are coming to the site to get vaccinated. And also, when we do the analysis of the different data on the site, we found out that people are not coming to the site because they have some problem, like transport problem, and they are not highly motivated to come until the vaccination home. So with this information, what we did in our strategy is that we reorganize the team so that we send some team on the community to get outreach vaccination. So instead of like having all the team staying on the sites, regarding the data that we have that show that people are not quite well motivated and don't have like transport fees to come until the vaccination drum. So we decided to modify our strategy so that we send 2 teams of vaccination every day in the community to get near to population and get them vaccinated. This has been very useful for us because day by day, we noted that we are able to vaccinate more people when we get into the community. So this is some example that I can give about this.
That's really helpful. I think it's always important to learn from what we've done and what we've, is keep improving and learn from the community members as to how we can better meet their needs. Robert, did you have anything to add to that?
Yes, we could also look at the client flow timing, where we have peak hours and low peak. For instance, so it could be on a daily basis, or it could be looking at a week schedule. So there are times during the day where you have a low peak, and there are times during the day over a period of time where, using your data, you are able to tell these are the peak hours of our vaccination. People are able to come in and get vaccinated at this time between 1 and 2 because they are leaving work to come and get vaccinated, or very early in the morning before they get vaccinated, or very late in the evening after work. And during those peak hours, you schedule your staffing in a way that you have enough staff in the peak hours than in the non-peak hours. So you don't have redundant staff seated at the vaccination site, and yet you have competing priorities that these staff need to address at their routine health facilities where they're supposed to be based. So that's one of the things we did in DLC, looking at the data and say what our peak hours in terms of time, and then what our peak days. We also noticed that we were getting more diverse groups of people over the weekend, children, women, men, on Saturday and Sunday. And therefore had to schedule our staffing in a way that we had more staff available on those days compared to the other days, so that we can handle the big turn-ups that appear on Sunday. For instance, after church, we could see a jump in number of people coming to get vaccinated on Sunday, or because our Ebola vaccines were for children, adolescents, and adults. And then on Friday, we could also see a peak in the afternoon. So we looked at the data, identified the peak hours and the low peak hours, and then scheduled our staffing based on the high peak hours where we have more staff. This is very critical because what you don't want is your new mass vaccination sites or new mass service delivery sites impacting on the routine work that these healthcare workers are supposed to do, and then you have a reaction from the communities where they're supposed to be served. where communities now start to complain that they have abandoned this and they are concentrating on this, and therefore it becomes an area that creates disharmony between the service providers and the community. So I think using data to map out that is very critical, and therefore using your resources in a way that it's not disruptive to the normal operations of the work is another best practice that I would recommend.
Thank you. Great point. We have one more question for CA, and then I have a question I'd like to pose as well. The last question that's come in is, did Village Reach have to consider any alternate staffing resources such as the ones that Robert described, or were you able to reach and access sufficient staff for the vaccinodromes without kind of exploring alternate resources? CA? CA, are you able to respond to that?
Hello, hello, can you hear me?
Yes, we can hear you. Thank you.
Okay. Yeah, in terms of staffing, what we did, as I explained in the presentation at the beginning, is that we have staff that have been hired by Village Reach, and also the government that gave, that supplied another staff. Most of the time it was a clinical staff. So we have also volunteer that join the team to do activity like community mobilization, community sensitization, so that these are people who join the team in order to help us improving our impact in the community. So I can say out of the two types of staff that we had, from the hiring of Village Reach and the staff that has been given by the government, the other source of staff that we get was the volunteer that joined the team most of the time to help in terms of sensitization and improve communication impact.
Thank you. And I know we don't have much time left, but I want to pose one question to both CA and Robert as we close this session and think about what we've learned so far, which is how are you capturing all of these lessons learned about staffing models for mass vaccination sites, or Robert, from your experience with mass service delivery as well, so that we can continue learning and improving and capturing them for the future as well. Would love to hear any thoughts from you as to kind of what the best way we can to share and store some of these lessons learned.
Hello.
Go ahead, Robert.
This is one of the platforms I would say really is doing a good job in getting this information out. The second one is having country level best practices right up. Usually when things are not written, with transition we lose most of what is good that has happened. Is it possible that at country level, people are writing down these best practices? When I worked in the Ebola programs, we did lessons learned. We used to do an annual lessons learned best practice documentation, which would bring all stakeholders together, one for learning, but also to put everything together and then share it within the country and external partners outside the country to see how they can learn from it and make use of it. The other is digitalizing some of the things that we are doing so that people can access them across boundaries, putting online the work that has been done and making it a global public good for ease of access.
Thank you. Over to you, CA.
Yeah, okay, thank you. So from our side in Cote d'Ivoire, what we are doing right now in terms of capturing all the lessons learned, we are developing a playbook for all the activities that we are doing, and in the playbook we try to capture all the lesson learned, all the activities that we are doing, for being able to have some documentation that will be useful for the other program. And also we are conducting a costing analysis in order to have a good understanding on what is the good cost model regarding the different strategy that we are setting up on the vaccine at home. So all this will be consolidated in the playbook that will show all the activities that we did on the vaccine at home.
That's fantastic. Thank you. Rebecca, next slide. Before we close out today, I want to just share a few things. First, we talked a bit at the onset of the session about our website with relevant resources, globalmassvaccination.com. We have a lot of resources about staffing that can add to this conversation as well, including staffing checklists and workflows and processes. So I encourage everyone to visit the site and explore some of these additional resources that we have. And we'll certainly be adding to this site, particularly as Village Reach completes their playbook, which I'm very excited about. I think that'll just add so much to this body of knowledge. Next slide, Rebecca. So as I said, please visit the website. There's a lot more information there. Please also take our post-session survey to share feedback on today's session and thoughts for future sessions as well. And you can join the Boost community, as we talked about. It's a community of immunization professionals and help you connect to peers, get support and resources to learn and grow as you work through this and many other challenging situations. Next slide. And finally, before we close, I just want to flag one really exciting upcoming opportunity. The WHO, in partnership with Sabins Boost Community, is offering a fellowship program for national and subnational immunization staff to support them as they plan and implement activities for the recovering and strengthening of your country's immunization programs. So the deadline to apply for this fellowship is coming up on May 6th. So please take a look. We'd love to have you join and continue a lot of the learnings we've been talking about through this series and many of Boost's other series as well. And I believe that is the last slide. So yes, thank you. So I just want to say thank you to everyone for joining today's session, particularly to Robert and CA for sharing all of your experiences and lessons learned. I know we've really contributed quite a bit to capturing both best practices and these lessons learned for that others can learn from and that can be saved and shared for the future as well. So I hope everyone has a great rest of the day. Please reach out if you have any questions, and thank you to you all for joining today's session. Have a good day.